Hello everyone, I hope I am live. Can you see me? Can you hear me? Let me confirm. If I'm clearly visible, audible, I will start with MCD. Okay, I think it will take a while. Just a second. So yeah, I hope it is working. So I welcome you all for today's session. A very good morning to all of you. I am Dr. Priyanka Sachdev here, and today this is the second session for today on YouTube. In the first session, we have already started glomerulonephritis. We have started primary glomerulonephritis, and among the primary, there are 9 types of primary glomerulonephritis. Among them, we have covered 2 in the last lecture. We have started with acute proliferative glomerulonephritis or post-streptococcal glomerulonephritis, the first one. And after that, we moved on the second one, that is RPGN, rapidly progressive glomerulonephritis. We have finished these 2. Let me start the third one, that is minimal change disease. It is a type of glomerulonephritis which occurs in children. Okay, let me brief you about it. So minimal change disease, also known as MCD, minimal change disease, right? Why it is known as minimal change disease? As I have told you that in glomerulonephritis, we see 3 microscopy: light microscopy, electron microscopy, and light microscopy, electron microscopy, and immunofluorescence microscopy. In light microscopy, we see HNE changes which are seen in the glomerulus during glomerulonephritis. In electron microscopy, I will see the composition, I'm not composition, I'm sorry, the location of the deposits, if there are deposits. And in immunofluorescence, I will see the composition of the deposits. That's it. In minimal change disease, here in minimal change disease, there is no change on light microscopy. Light microscopy is absolutely normal. There is minimal change in light microscopy. That's why it is known as minimal change disease. In immunofluorescence also, there are no change. It is normal because there are no deposits. It is also post-immune. The only change seen in electron microscopy here. Have you got it? So it will lead to nephrotic syndrome. The first 2, that is APGN and PSGN, were leading to nephritic syndrome. But this one leads to nephrotic syndrome, right? So it is a nephrotic syndrome with no change on light microscopy. Because there is no change on light microscopy, that's why it is known as minimal change disease. Have you got it? It is known as minimal change disease. It is also known as lipoid nephrosis. It is also known as lipoid nephrosis. It is also known as food process disease. I will tell you the reason why it is known as food. It is known as nil deposit disease. I will explain you the meaning of all these, right? It basically occurs in children. MCD, minimal change disease, occurs in children. 80% of the patients are children. Rather, it is the most common cause of nephrotic syndrome in children. It is the most common cause of nephrotic syndrome in children. Usually it occurs less than 16 years of age ke children mein, and it is more common in males. Right. Now coming on etiopathogenesis, it is not known actually, or it is cell mediated. It is not antigen antibody mediated. It is cell mediated glomerulonephritis. That is known as delayed type of hypersensitivity. So actually what is happening here, the activated T lymphocytes, CD4 and CD8 T lymphocyte, they will secrete certain cytokines. And that cytokines along with the cells causes cytotoxicity inside the glomerular filtration barrier. So that will lead to glomerulonephritis. So here glomerulonephritis is not due to antigen antibody complex. Since no complexes are formed, it is known as no immune complexes are formed. It is known as nil deposit disease. Nil deposit. That is one of the name given to it. I have told you na here. It is known as nil deposit. Why? Because no antigen antibody complexes are formed. Because in etiopathogenesis, antibody do not have any role. It is due to cell mediated. Cell mediated. That's why it is also known as posse immune. Posse immune means posse means less. So less immune complexes or no immune complexes are there. So please learn these terminologies. It is due to T lymphocytes which is causing glomerulonephritis here. It is not antibodies or antigen antibody complexes which is causing glomerulonephritis like the other 2 previous one. Have you got it? Grossly kidney is normal. It is not flea bitten. It is not large white. It is normal kidney. Microscopy, the first microscopy is the light microscopy. Light microscopy is absolutely normal. No abnormality. It is normal. Absolutely normal. See the glomerulus. Is it hypercellular? Can you see a glomerulus here? Yes, of course you can see a glomerulus. Is it hypercellular? No, it is not hypercellular. Is it hyperproliferative? No. Is it enlarged? No. Is it infiltrated by WBC? No. And is it having any crescent formation? No. It is normal glomerulus, looking like absolutely normal. Can you see? Absolutely normal glomerulus. So that's why it is known as minimal change disease, because the glomerulus is normal. There is no change in glomerulus on light microscopy. That's why it is known as minimal. change disease, because hardly you can find any change here. That's why it is known as minimal change disease. Have you got it? On electron microscopy, if you see, there are no deposits. Now, what is the diagram of normal filtration barrier on electron microscopy? Can you tell me the diagram? Yes, you can. So listen, there is a basement membrane at the center. Normally, this is basement membrane. On one side, you will get endothelium. This is the endothelium. On other side, what is there on the other side? You will get podocytes. What is known as podocytes? See the shape of the cells. The shape of the cells is like the foot of human, like the foot of the human. That's why known as foot processes, or also known as podocytes. Also known as podocytes, right? This is normal. This is normal. Normal. What will happen in MCD? What will happen in MCD? In MCD, basement membrane is normal. You can see it is absolutely normal. Like this, it is the same basement membrane, right? Endothelium is also normal. Like this, here also we have a normal endothelium. But what about the food processes? What will happen to the food processes? Food processes shape will become like this. So it is known as, what it is known as? It is known as flattening of food processes. So food processes become flattened, or it is known as effacement, the same thing. Effacement of the food processes, or it is known as fusion of the food processes. Food processes, or it is known as loss of food processes. So whatever you say, either flattening of food process, effacement of food process, fusion of food process, or loss. Now compare the shape both ways. Compare the shape here, compare the shape here. So that is the thing seen in MCD. In MCD, there are no deposits. It is not any deposit intramembranous or subepithelial or subendothelial or mesangial. No, there are no deposits. There is flattening, effacement, fusion, or loss of the food processes. Please learn all these terminologies. So sometime in your exam, the examiner will say flattening. Sometime he will say effacement. Sometime fusion or loss. So you should know the meaning of all these same. Have you got it? So there is flattening. There is diffuse flattening or effacement of the food process of the visceral epithelia, that is podocyte. But there are no deposits and GBM is normal. Basement membrane. See this diagram. Can you see it is flattened? There are no food. This one is flattened. This one is flattened. Can you see the flatness? But there are no deposits. Flattening of the podocyte is a feature on electron microscopy. Please appreciate the flatness here. Please appreciate the flatness. It is flattened. Please appreciate the flatness. Right? And you can compare. This is normal. Can you see the normal? And here it is flattened. In this disease, it is flattened. Have you got it? Immunofluorescence tell us the composition of the deposit. लेकिन composition बताने के लिए deposit होना तो चाहिए. There is no deposit. No deposit because it is nil deposit disease. So no deposit, no composition. Have you got it? So there are three type of microscopy. The summary is in front of you. What about light microscopy? What about electron microscopy? What about immunofluorescence microscopy? Who will tell me? On light microscopy, it is normal. There is no abnormality. On immunofluorescence also, it is normal. There is no deposit. So this one is normal. This one is normal. So how we will make the diagnosis? Diagnosis is made only on basis of electron microscopy. So there is loss of or fusion of food processes or obliteration of food processes. That is the feature seen on electron microscopy. Everyone give me a thumbs up. So you can say MCD is a disease of children, of glomerulonephritis of children, in which the diagnosis is made only based on electron microscopy. Light microscopy and immunofluorescence microscopy is normal. So no need to do it, right? Only electron microscopy will give you the diagnosis. Coming on clinical feature, MCD leads to nephrotic syndrome. Have I told you the differences between nephritic and nephrotic syndrome in the last lecture? Yes or no? Those who have attended my yesterday's lecture, they know the differences between nephritic syndrome and nephrotic syndrome. Yes or no? What are the differences? In nephritic syndrome, patient comes with 5 features. Number 1, hematuria, that is blood in urine. Number 2, mild proteinuria. There is protein in the urine, but it is mild. Mild edema, mild edema, mild edema, right? Hypertension. Patient will have increased blood pressure and oliguria. These are the 5 features present in nephritic. But in nephrotic, coming on nephrotic syndrome, okay, there is no hematuria. There is no hematuria. Proteinuria is there, but it is severe. Severe proteinuria, selective and severe. Only albumin come out. Edema is there, but it is severe. It is severe edema. It is severe edema. If you say about edema, here edema occurs only around the eyes. Periorbital edema. Here edema occurs throughout the body. It is severe and throughout the body. I have told you the reason also, right? And there is the no hypertension, no oliguria, but other 3 findings are there. Severe proteinuria, severe edema. Apart from it, The patient have, what the patient, the third, hypoalbuminemia, hyperlipidemia, hyperlipiduria, and hypercoagulopathy. So these are the features of nephrotic syndrome. As till now, this is the third glomerulonephritis I am teaching you. Yes or no? The first one was APGN. So APGN leads to nephritic syndrome. The second one was RPGN, APGN or PSGN, one and the same thing, right? PSGN. Second is RPGN. Three types of RPGN all leads to nephritic syndrome, right? Rather, RPGN is the most common cause of nephritic syndrome. Coming on nephrotic, the third glomerulonephritis, MCD, which is the glomerulonephritis of children, leads to nephrotic syndrome. So please learn, because I will launch some clinical questions right now. So in the clinical questions, you will get a clue whether the patient is having nephritic syndrome or nephrotic syndrome. The biggest clue is presence or absence of hematuria. That will differentiate, because proteinuria is present in both, edema is present in both. Although here it is mild, here it is severe. But hematuria is a thing which is present only in nephritic but not in nephrotic. So you should differentiate whether the examiner is pointing towards nephritic, so your options will be different. Or whether the examiner is pointing toward nephrotic, the options will be different. These two nephritis, glomerulonephritis, APGN and RPGN, occurs in adults, right? But MCD occurs in children. MCD leads to nephrotic. Have you got it? So it will lead to nephrotic syndrome with massive proteinuria in children, right? Children will come to you with massive proteinuria. Prognosis is very good if you give steroid. It is steroid responsive glomerulonephritis. Most of the glomerulonephritis are steroid resistant. They do not respond to steroids. But here is one of them, one of the glomerulonephritis which responds very good. The response, you give a single dose of steroid or prednisolone, the child will be absolutely all right. Have you got it? Let me compare the first three. Anyone, Rishinika, would you help me to compare the first three glomerulonephritis? So what are the first three? APGN, that is PSGN, post-streptococcal, RPGN, that is rapidly progressive, and MCD, minimal change, right? This one occurs in adults, this one occurs in adults, this one occurs in children. First, take age in consideration. Age is always important. What about etiology? Who will tell me the etiology? APGN, etiology is antigen antibody complex formation. In situ antigen antibody complex formation, which is formed against a planted antigen. Planted antigen is bacteria. RPGN is of three types, as I have told you: type 1, type 2, type 3. Type 1, it is in situ formation but against fixed antigen. Type 2, in situ antigen antibody complex formation against a planted antigen. Fixed antigen is collagen. Planted antigen is again bacteria. Type 3, it is cellular. It is cellular. No deposits are formed. It is cellular. In MCD also it is cellular, posse-immune. So can I say type 3 RPGN and MCD both are posse-immune? Both have cellular mechanism of glomerulonephritis? Yes, yes. Yes, Rishinika, you are absolutely right. It is flea-bitten kidney. I'm coming on the cross. In APGN, it is flea-bitten kidney. What about RPGN? In RPGN, it is large kidney, large white kidney. What about minimal change, Rishinika? Normal. Kidney is absolutely normal here. Normal is the thing which you should take in consideration. So the kidney is having a disease, still it is looking normal. Coming on light microscopy of all of them. Okay. In light microscopy, in APGN and RPGN, the kidney is enlarged in size, both of them. In both of them, the kidney is hypercellular. In both of them, the kidney is hyperproliferative. In both of them, the kidney is infiltrated by WBCs, that is neutrophil and lymphocyte. But in APGN, crescents are absent. In RPGN, crescents are present. That is the differentiating feature between them. But what about light microscopy of minimal change disease? What about light microscopy of minimal change disease? Write down it is normal. So please, bold letters may write down it is normal. That's why it is known as minimal change. The name is arrived from this only. Minimal change means no change. On light microscopy, there is no change. Have you got it? Coming on electron microscopy of all of them. Electron microscopy of APGN, you will find the deposits. What is the location of deposit? Here it is subepithelial. Subepithelial, lumpy, bumpy, humpy, dumpy deposits. Big deposits. Subepithelial. In RPGN, if you say type 1, it will be intramembranous deposit. If you say type 2, it will be again subepithelial deposit. If you say type 3, there are no deposits. There are no deposits. So we are done with type 1, 2, 3. Very good, Rishinika. Very good, Paul. Very good. Very good. Okay. What about minimal change disease ki electron microscopy? Who will tell me? So in minimal change disease on electron microscopy, we didn't get deposits. Deposits तो होते ही नहीं है, neither subepithelial nor intramembranous, not anywhere else. we will find here food process की flattening. Either you say flattening of food process, effacement of food process, fusion of food process, obliteration of food process, loss of food process. The meaning is same. So there is a problem with podocytes. Food process means podocytes. The visceral epithelium, that is problematic. Give me a thumbs up. So here it is known as minimal change disease में the electron microscopy. Coming on last, immunofluorescence. Who will tell me the immunofluorescence of all? Immunofluorescence. So in APGN, immunofluorescence में you have to tell me the composition of the deposits. Here composition is IgG plus C3. Here also composition is IgG plus C3. But here no composition because no deposit. Deposit ही नहीं है तो composition का आएगा. That's it. Everyone give me a big thumbs up. I'm doing a big comparison for you all. So these 9 type of glomerulonephritis will be super simplified for you if you understand this table well. So not only in pathology, but in medicine also. So it is a big topic in pathology as well as in medicine. Yes or no? Coming on the 4th and 5th type of glomerulonephritis together. I am taking these two together. Membranous glomerulonephritis and membranoproliferative glomerulonephritis. I will take these two together. Okay. So, okay. Before that, there are few polls based on minimal change glomerulonephritis. We will see few polls, few questions. The first question is in front of you. What is true about light microscopy of minimal change disease? I'm asking, please mind my words. Rishinika, Paul, anyone else, mind my words. I'm asking light microscopy. Would you like to answer? Light microscopy, what you will see in minimal change disease? What you will see? Will you see loss of food process? Yes. Will you see anti-GBM antibodies? Yes. Will you see IgA deposits? Yes. Or will you see no change? What? So Rishinika, you are absolutely right. You will see no change because I am asking on light microscopy. Rishinika, I am changing the question a little bit. Instead of light microscopy, I am asking electron microscopy. What is your answer now? In the same question. True about electron microscopy in minimal change disease. Now, what is your question? Instead of light microscopy, if I say electron microscopy, what is your answer now? I'm asking. Anyone want to answer? Yes? Just a second. Anyone want to answer? Very good, Rishinika. In that case, your answer will become A. It is the loss of food process which is seen on electron microscopy. Right or not? Instead of that, if I'm asking light microscopy only and instead of minimal change disease, I am asking for Goodpasture disease. What is your answer now? In Goodpasture disease, what you will see? What you will see? What is the hallmark of Goodpasture disease? In that case, yes, you are right. Your answer will become B. It is anti-GBM antibodies are seen, right, in the Goodpasture disease. So your answer will become E. If instead of that I am asking for IgA nephropathy or Berger disease, you will say IgA deposits are seen. So if I'm changing the question a little bit, answer will change. So your concept should be strong. Give me a thumbs up. This is the next question in front of you. What is true about minimal change disease? Read the 4 statement and tell me which is true statement about minimal change glomerulonephritis or minimal change disease which occurs in children. Who will tell me? The 4 options are in front of you. It appears normal under light microscopy, but electron microscopy shows loss of food process. Is it a true statement? Yes or no? Read other 3 also. Read other 3 options also. Mesangial deposits are seen. Tram tract deposits are seen or gross hematuria is seen. So Rishinika, you are absolutely right. The correct answer among these is A. Yes. On light microscopy, it is normal. And on electron microscopy, there is loss of food process. This statement is right. But there are no deposits. None of the location have deposits. So mesangial deposit is a wrong option. Tram tract appearance is seen in membranous glomerulonephritis, not in minimal change. So this is wrong. Hematuria is seen in nephritic syndrome. Nephritic syndrome. But I have told you that minimal change disease leads to nephrotic syndrome. So here hematuria is absent. Not gross hematuria, it is absent. That's why the statement is also wrong. So other 3 are wrong. The first is the right. Rishinika, right? The correct answer is A. The next is a clinical question. I will read it for you. Listen, see the age. A 7-year-old girl is coming to your clinic with the parents. Parents are bringing their girl to you. 7-year-old girl, a cute girl is there, a small girl is there in your clinic. So you will say, what is your complaint, dear? Why you are in my clinic? So you will ask the parents, what is the complaint of your baby? So they will say, she is having generalized swelling of throughout the body. Her face is puffy and she's generalized having swelling throughout. Imagine a girl, a cute girl in your clinic. So this may happen if you really work in practice after few years. So a little girl is coming with the parents and she's swollen all throughout the body. You have immediately ordered urine examination. You are suspecting something in kidney, something wrong in the kidney of the child. So you have ordered urinary examination. Urinary examination grade 3 proteinuria. By grade 3, I mean severe proteinuria. It is not grade 1, grade 2, it is grade 3. The highest grade, severe proteinuria. and presence of hyaline cast and fatty cast. Fatty cast indicate lipiduria. So patient is having severe proteinuria and lipiduria. She has no history of hematuria. You ask the parent, does the urine is red anytime? No, there is no blood in urine. Hematuria is absent. This negative finding is really very important. So in a child, now this history indicating severe proteinuria, lipiduria, no hematuria. Three things are given in the question one by one. Severe proteinuria, lipiduria, no hematuria. It indicates nephrotic syndrome. This indicates nephrotic. You know what is nephrotic. So in a child, the most common cause of nephrotic syndrome, what is your diagnosis? The diagnosis is NCD. The diagnosis is NCD. Now make first diagnosis. Now read the four options. You will be on the answer. So you will be on the answer. So read the four options. There are no IgG deposit or C3 deposition on renal biopsy. Yes, this is true for MCD. Yes, Rishinika, you are right. Her C3 level will be low. No, C3 level will be normal. C3 level कब होगा? Whenever we have deposits, the patient have deposits in the kidney. The deposits are made up of IgG plus C3. So C3 will be utilized in the formation of the deposit in the kidney. So blood level of C3 will be low. But here blood level of C3 will not low. It will be normal because no deposits are there. So this statement is wrong. IgA nephropathy is the diagnosis. No, my diagnosis is MCD, not IgA, because IgA do not occur in children. It occurs in adults. It can occur in children also. But in IgA, there is nephritic syndrome. So patient will have hematuria. Hematuria is a feature of IgA. So that's why I'm ruling out IgA, right? And Alport syndrome, no. Alport syndrome with three things are there. Sensory neural deafness. So ear involved first, then kidney. Ear, eye and kidney. These are the three organs involved here, and it is congenital. Not present at the age of 7. It is congenital, right? It is hereditary. So again, this is ruling out. So correct answer here is A. Have you got it? Have you got it? Yes or no? Yes or no? Should I proceed ahead? So let me proceed ahead. So correct answer here is A. So first make the diagnosis. The same question with a little bit change. I will read it. So here in this week, clinical questions are coming in your exam. See, a 10-year-old girl is there. A 10-year-old child. See the age. Age is always, always, always important. Please take it in consideration. So some disease which is taking place in child. Imagine a 10-year-old boy now in your, a small boy in your clinic with the parents. He is having edema and he is having decreased urinary output. So renal failure is there. On examination, you have seen albumin is 2.5. So blood albumin is less. So patient is having hypoalbuminemia and creatinine is normal. Creatinine is normal. Urine is protein. Urine में protein is 3 plus. Grade 3 proteinuria, severe proteinuria, but no RBC, no hematuria. So severe proteinuria, no hematuria, and hypoalbuminemia in a child indicates what? So four options are in front of you. Is it indicating interstitial nephritis? Is it indicating MCD? Is it indicating IgA nephropathy? Is it indicating membranous nephropathy? So the clues in the question, child is the first clue. Severe proteinuria is the second clue. No hematuria is the third clue. And hypoalbuminemia is the fourth clue. So four clues are given in your question. Four clues. Compiling all together, you will reach to your answer. Of course, Rishinika, the answer here is MCD. So most common cause of nephrotic. This is indicating nephrotic syndrome. So most common cause of nephrotic syndrome in a child. The answer is minimal change disease. If I change the question, instead of 10, I take 50 years. The same findings, everything is same. What is your answer now, Rishinika? What is your answer? What is your answer? Now, Damin, Paul, Rishinika, what is your answer now? Anyone else? What is your answer? I'm changing just age, nothing else. So what is the most common cause of nephrotic syndrome in adults? Instead of child, it become an adult. Adult, the same clinical finding. So patient is presenting with severe proteinuria, no hematuria and hypoalbuminemia. That is nephrotic syndrome, but not in children. Now the answer will become membranous nephropathy. So membranous nephropathy will be the answer. D will be the answer. Have you got it? So a little bit change in the question can change your answer. You have to be very attentive and careful in your example. You have to be beware, right? Read your question thoroughly. So that is the importance of age here, right? The same question. Now the students who are mugging up the answer, they won't realize that the age is changed. So changing the age will change the answer. Have you got it? Have you got it? So that's why approach. I always insist on approach. The approach to the question is important. It is not the knowledge you are having. Of course, you have to apply the knowledge. But once you have read everything of all 19 subject now, how you approach, your approach towards question, your approach towards exam, Your approach towards life defines you, defines your personality. So it is the approach, how you take everything, so lightly, so coolly, so tense, or what, how important things are for you, and in which sequence you are arranging them. So that is the approach, right? Okay, let me come on the next question. All are steroid resistant glomerulonephritis except. So one of the glomerulonephritis is steroid responsive. I have told you the treatment of MCD. MCD ka treatment is responsive, responsive to steroid. So of course the answer here is minimal change glomerulonephritis because it is responsive to steroid. But other glomerulonephritis do not respond to steroid. So steroid sensitive glomerulonephritis is the only one, that is MCD. All other glomerulonephritis are steroid resistant. Give me a thumbs up. Okay. So I'm done with the three till now. Till now, we have done APGN. Till now, that is PSGN. We have done RPGN, and we have done MCD. You know the etiopath, you know the age, you know the nephrotic, you know everything about them. Let me start the fourth and fifth together. Membranous and membranoproliferative glomerulonephritis. I will take these two together. So five will be done, right? So let me start with membranous. Membranous and membranoproliferative, I will tell you together. Membranous glomerulonephritis. It is also known as epimembranous nephropathy. It is the most common cause of nephrotic syndrome in adults. I have changed the age in the last question now. Here in this question, if instead of 10, I am doing 50, my answer is membranous. Because what is the summary I want to say here? The summary is that if you talk about nephritic syndrome and if you talk about nephrotic syndrome, most common cause of nephritic syndrome, it is same in children as well as adult. But most common cause of nephrotic syndrome is different in children, is different in adults. So you have three answers, right? Nephritic syndrome answer is always RPGN. RPGN is the most common cause of nephritic syndrome in adults as well as in children. But if you talk about nephrotic syndrome, in child, answer is MCD, minimal change disease. But in adults, the answer is membranous glomerulonephritis. Have you got it? Have you got it? So in children, the most common cause of nephritic syndrome, we have already studied MCD. Now adults, may most common cause of nephrotic syndrome is membranous glomerulonephritis that we are starting right now. Have you got it? It is also known as epimembranous glomerulonephropathy. Let me show you the diagram of the two. So I will explain you the two together. Just a second. Okay, let me see where is the diagram of the two together. A comparative diagram. This one. I want to explain you this one. Listen, the first is the diagram of membranous glomerulonephritis. And the second is the diagram of membranoproliferative glomerulonephritis. You will see, ma'am, what is the difference between the two? Membranous and membranoproliferative. As the name indicates, what do you mean by membranous? And here it is membranoproliferative. Here it is membranous glomerulonephritis. Here it is membranous proliferative glomerulonephritis. What I mean, membranous का मतलब है thickening of the GBM. You know, both of them have GBM. Let me draw a GBM. Okay, I will draw a GBM. So here GBM will become thickened. In both of them, the GBM is thickened. This is the basement membrane at the center. Now, it will get thickened in both of them. That's why both of them are membranous. Membranous terminology is common in both of them. Now, on one side, there is endothelium. Endothelium is normal in both of them. This is the endothelium. On other side, there is visceral podocyte or epithelium. So visceral podocyte or food processor epithelium, it is also normal in both of them. But what is the problem? The problem is the basement membrane. So basement membrane is thickened in both of them. Thickening of the basement membrane here also, here also. That's why both of them are membranous. In the first, it is the only finding, thickening of the basement membrane. That's why it is known as membranous glomerulonephritis. That's it. That's it. But in the second one, along with membranous thickening, there is proliferation also. Proliferative, membranoproliferative. What do you mean by proliferation? Proliferation means cellularity. Cellularity. There will be increased cellularity. As we have seen increased cellularity in PSGN, we have seen increased cellularity in RPGN. So that is increased cellularity, increased proliferation. Have you got it? But there is no cellularity. Now see the two diagram, you yourself will understand what I have taught you. So see this one. मैंने उल्टा लिखा है. I'm sorry. And see this one. Okay, let me correct myself. This is MGN, membranous, and this is membranoproliferative. Now see. Now see. Now first see MGN, that is membranous globule. So you can see only thickening of the basement membrane. This basement membrane is thickened than normal. It is more clearly seen on pass. It is thickened. It is thickened, but you cannot see the cellularity. Cells are normal. The inner lining is endothelium, the outer lining is epithelium. That's it. But only thing, the thickening of the basement membrane. Krishinika, appreciate this thickening. Can you appreciate this thickening? In this diagram, in MPGN, membranoproliferative, you will see thickening to, hey, this is endothelium, this is epithelium. So in between the two endo and epithelium, you have basement membrane. So basement membrane is thickened here also. But in between endo and epithelium, there are cells also. Let me mark the cells. These all cells. Some of them are lymphocytes, some of them are neutrophils. So cellularity is also there. Have you got it? Now compare the two. Here only thickening is there. Here, along with thickening of the basement membrane, cellularity is also there. Have you got it? Have you got it? That is the two type of next glomerulonephritis. Everyone give me a thumbs up. Everyone. Means I'm doing the concepts for you. I'm building the concepts. I'm more interested in building the concepts. Right? If I also teach like, most of the educators which are teaching, I will also summarize the findings. But you should have a concept in your mind. Have you got it? So let me start with membranous. Membranous. And then I will come on membranoproliferative. Membranous is also known as epimembranous because it is only the thickening of the membrane. That's it. It's the most common cause of nephrotic syndrome in adults. Right? That is the introduction. Etiopathogenesis. Okay. GP330. Okay. Okay. I will tell you the etiopathogenesis. What is etiopathogenesis? Listen here. Very beautiful. So why there is thickening of the basement membrane? Why? So see in the center, this is the basement membrane. On one side, there is endothelium. On other side, this is visceral podocyte. Let me draw visceral podocyte. On visceral podocyte, there is an antigen. There is a protein or antigen which is known as glycoprotein 330. It is present in all of us, in you, in me, in everyone. GP330. So glycoprotein 330 is the antigen or protein present, like collagen is present in the basement membrane. Now, in the same way, GP330 is present in the podocytes. Now, body is forming antibodies against it. Body is considering it as the autoantigen or as a foreign particle, and body is forming antibodies against it in the blood. These antibodies are coming and forming antigen antibody complexes here. So where the antigen antibody complexes are formed, they are not formed in blood. They are formed in C2 against a fixed antigen. But what is the fixed antigen here? The fixed antigen is glycoprotein 330 protein present on the podocyte. So it is the same way as that of good pasture. In the good pasture, the antigen was collagen, type 4 collagen ka alpha 3 NC1 domain that is present on basement membrane. Here the antigen is GP330 which is present on the podocyte. Give me a thumbs up. So body is forming antibodies against it. So you may ask one question. Students usually ask this question to me, ma'am, there should be thickening of the podocyte. Now, why you are saying thickening of the basement membrane? Actually, yeah, you are right. There should be thickening of the podocyte. But on light microscopy, it is visible that basement membrane is thickened. Actually, because of this antigen antibody complex formation, neutrophil will come here. The complexes will attract the neutrophil. It will attract the inflammation, and neutrophil will come between epithelium and endothelium and separate the epithelium and endothelium in the basement membrane. So basement membrane get thickened. Give me a thumbs up if you got the etiology. So what is the etiology here? Who will tell me? So what is the antigen? Antigen is the protein component of podocyte, which is a fixed antigen. The name of the antigen is glycoprotein 330. Body is forming antibodies against it, and antigen antibody complexes are formed in C2 against a fixed antigen. It will lead to acute renal failure. Give me a thumbs up, Rishinika, if you got it. Give me a thumbs up. Have you got it? Have you got it? Sometimes we can do it in a rat. We take a rat or we take a mouse. This is a rat or mouse with a tail. Have you got it? This is a rat or mouse, right? Now this is the kidney of the rat or mouse. This is the kidney inside the rat or mouse. So what we do the same experiment in the rat. Experimental. So experimental of the same, that is membranous glomerulonephritis, inside some experimental model. It is known as Hamin model of the red glomerulonephritis. So we can see it inside that, right? Grossly, the kidney is enlarged, nothing important. Light microscopy, I have already explained you. This is the diagram of light microscopy. What you can see, you will see, ma'am, these are the capillaries, the lumen of the capillaries. Can you see the lining? This flattened lining of the lumen of the capillaries. Appreciate the flattened lining. This is all endothelial cells. These are endothelial cells. And please appreciate the epithelium. That is visceral podocyte. This is the visceral podocyte. And in between the two, what you can see? In between the two, can you see something? You can see the basement membrane which is thickened. Give me a thumbs up. The basement membrane between the two is thickened. This is the basement membrane. So it is the diffuse thickening of the basement membrane. Basement membrane is thickened, so it is looking there are two basement membrane. Actually, it is one, but thickening leads to duplication. It is not duplicated. It is one only. But because of the thickening, because of the thickened basement membrane, it is looking like duplication of the basement membrane. There is no cellularity. Appreciate my words. Mind my words. In membranoproliferative glomerulonephritis, there is cellularity, but here there is only thickening, nothing else. That's it, the light microscopy. Thickening is more visible instead of HNE if you do pass. If you do pass staining or silver staining, na, thickening is more appreciated. See, this is the silver staining. In the silver staining, can you see the purple thing? Whatever purple is that, this is the basement membrane. Please appreciate the thickness of the basement membrane. Give me a thumbs up. It is pass, sorry, not silver. Have you got it? So that is the basement membrane. On electron microscopy, deposits will be there. Where the deposits will be there? Deposits will be there on the podocytes, because here antigen antibody complexes are formed on the podocyte against GP330 antigen of the podocyte. So subepithelial location, and it will be in the shape of the spikes. Subepithelial और कहाँ पड़ा है? Where you have studied subepithelial deposits. So we have studied these subepithelial deposits at one place more. Who will tell me what is that place? One more place we have studied this subepithelial deposits. In the PSGN, the first one, the PSGN or type 2 RPGN, right? Okay, let me draw it. I will explain you. I want to explain you something here. The last concept. Okay. So you can appreciate the filtration barrier, right? So I have told you that in PSGN or same with type 2 RPGN. RPGN is same as type 2 RPGN is same as that of PSGN. And this is M minimal membranous glomerulonephritis. In both of them, subepithelial deposits are there. Here the antigen was planted, a bacteria. And here the antigen is fixed. That is GP330. GP glycoprotein 330. It is a planted antigen and it is a fixed antigen. Have you realized the difference? So here also antigen antibody complexes are formed, and here also antigen antibody. So antigen antibody complexes are seen subepithelial, but the shape is different. Here the complexes, antigen antibody complexes are seen lumpy, bumpy, humpy. See the shape. Here they are formed in the form of spike. So please appreciate the difference between humpy deposits, and please appreciate the difference between spike. Have you got it? Let me fill one of the shape. This is a spike and this is a lumpy, bumpy, humpy. Give me a thumbs up. I'm really trying hard to give you the concepts. Have you got it? Now please appreciate the spikes. Have you realized the difference? So this is the spikes. Appreciate the spikes. The dark pink color. Appreciate the dark black color are the spikes. Give me a thumbs up. Give me a thumbs up. Immunofluorescence composition is same. IgG plus C3. That's it. IgG plus C3. It is granular IgG plus C3. So I'm done with membranous also, but the time is limited, so I have to stop here. I will continue with membranoproliferative and others tomorrow in the next lecture. Are you people prepared? Are you people prepared for it? Yes. So, okay, just a second. Let me announce my next lecture today. This I will continue tomorrow, and I'm stopping here this today. So thank you very much for being with me. I really enjoyed teaching you. My next class is currently I'm having a plus class. The next class 10 to 12. 10 to 12. Right now after 5 minutes, 10 a.m. to 12 p.m. I'm having a plus class. So if you're a plus subscriber, you please join me there. I will teach you hemodynamics, shock, and bleeding disorder platelets in these 2 hours, right? After that, I'm having what is my next class? Yeah, in the afternoon, I'm having 2 more classes. One is 3:15 to 4:15, free special class, and one is 4:30 to 5:30. Free special class today only PM. In the afternoon, in the evening, I'm having these 2 classes. In these 2 classes, I'm going to teach you new image based question. This is from respiratory pathology. The most of the questions will be from radiology and histopathology, and this is renal pathology. So please, you have studied the glomerulonephritis now. You will have a better understanding of this now. So please join me for the free classes today. IBQ marathon, 2 IBQ marathon I'm going to take. Thank you very much for being with me. And yeah, NEET PG notes are out. The hard copy of the notes, you can purchase it. Unacademy is making you available the hard copy of the notes. If you're taking a plus subscription of 1 year and more, the notes copy is free to you. So you can check the various plans of the plus which are more than 1 year. And you can check the price. And if you apply my code is Sachdev10, SACHDEV, Sachdev10. Just before the payment, you will get this price. You will get maximum discount and you will get the notes along with the subscription at this price. And price hike is coming soon, so please grab the opportunity. On Unacademy, we have 2 type of subscription. Plus, you will get access to Unacademy. Iconic, along with Unacademy, you will get access to Prep Ladder also. Once you take the subscription, you will be eligible for all these batches with the top educators, right? So don't miss out this opportunity. Take the subscription and add a level more in your preparation. Thank you very much. Study hard. Bye-bye. See you all today afternoon 3:15 p.m. at free special class. Bye-bye. Study hard. And I'm